Analgesics are the medication class. An means without. Gesic is the Greek word to feel pain. So analgesic means without pain. Some over-the-counter analgesics include NSAIDs, which are non-steroidal anti-inflammatory drugs, acetaminophen, otherwise known as Tylenol, and aspirin. First analgesic that we're going to go over are NSAIDs, non-steroidal anti-inflammatory drugs. The prototype for this medication is ibuprofen, or Advil is the trade name. The mechanism for action for NSAIDs is that they interfere with the production of prostaglandins, which in turn inhibits mild pain and suppresses inflammation. So both pain and inflammation are suppressed by NSAIDs. First generation NSAIDs, also called COX-1 and COX-2 inhibitors. The first generation of non-steroidal anti-inflammatory drugs, or NSAIDs, suppress inflammation, treat mild to moderate pain, reduce fever, and relieve dysmenorrhea, which is painful menses. Again, ibuprofen is the prototype for this medication, and it's one of your drug cards. Aspirin is also a prototype for this class of medications. Other medications in this category include naproxen, indomethacin, ketorolac or Toradol, and diclofenac. NSAIDs like ibuprofen generally come in enteric-coated or sustained release forms. They should be taken whole and not crushed or chewed. NSAIDs can cause bleeding as a side effect, but they're not used as antiplatelets, but you should still stop aspirin 1 week before a scheduled surgery. Aspirin can be given prophylactically to inhibit platelet aggregation. That's usually a baby aspirin, which is 81 milligrams per day. This is different than the medications such as warfarin or Coumadin, which has more adverse drug reactions and medication interactions. The slide shows that NSAIDs, like ibuprofen, are antipyretic, analgesic, and anti-inflammatory. Adverse drug reactions of NSAIDs relate to the inhibition of the protective effects of COX-1. So you can get gastric upset, heartburn, nausea, and gastric ulceration secondary to blocking the gastromucosal protective effects of COX-1. Bleeding tendencies occur for the same reason. However, this occurs less with non-aspirin NSAIDs. Renal dysfunction is also an adverse drug reaction because NSAIDs block the protective effects of COX-1 on the kidneys. So NSAIDs, think nephrotoxic. In addition to these effects that relate to the inhibition of COX-1, there are other adverse drug reactions. An increased risk for thromboembolic events exists when clients take a non-aspirin NSAID. That means clots can form. Salicylism, which is a buildup of aspirin in the body to toxic levels, can occur if clients ingest more aspirin than they excrete. Then there's Ray's syndrome, which is a rare but serious disorder that occurs secondary to giving aspirin to a child who has a viral infection. Therefore, aspirin was removed from most products intended for children under the age of 18. NSAIDs can also cause fluid retention, which will increase the workload of the heart and could cause hypertension. Because of that fluid retention, you could also have worsening of heart failure. And then again, clot formation can happen from NSAIDs that aren't aspirin. There are many contraindications to using aspirin. First, it is a pregnancy risk teratogenic medication, meaning it harms fetuses, so women who are pregnant should not take it. Clients who are hypersensitive to aspirin or other NSAIDs should also avoid taking aspirin. Clients who have peptic ulcer disease or a bleeding disorder such as hemophilia or vitamin K deficiency, and children or adolescents with chickenpox or influenza should avoid taking aspirin. Clients who are perioperative before coronary artery bypass surgery should avoid taking non-aspirin NSAIDs, and aspirin itself needs to be discontinued within 1 week of any elective surgery due to the risk of bleeding. Use aspirin with caution in clients who are older adults, who smoke, who have alcohol use disorder, have a Helicobacter pylori infection, heart failure, and or advanced kidney dysfunction. Non-aspirin NSAIDs are a contraindication in clients who have hypertension. Remember that the use of aspirin along with anticoagulants, glucocorticoids, and alcohol increases the client's risk of bleeding. Ibuprofen decreases the antiplatelet effect of low-dose aspirin. The risk of using aspirin along with ACE inhibitors increases the risk of renal failure, as well as decreasing the antihypertensive effects of ACE inhibitors. So patients who have asthma should not be taking NSAIDs. In caring for a client taking non-selective NSAIDs, monitor for manifestations of bleeding, including black or tarry stools, abdominal pain, nausea, and hematemesis, which is vomiting blood. When taking NSAIDs, you should test for and treat Helicobacter pylori. That is a type of gastric ulcer. Monitor patients for petechiae or easy bruising, which manifests as pinpoint hemorrhages below the skin and excessive bleeding from minor injuries such as cuts from shaving. Monitor for a decrease in renal function from total of INO and decreasing levels of BUN and creatinine. In relation to the potential for salicylism in clients taking aspirin, monitor for client reports of tinnitus, dizziness, and or headache, as well as diaphoresis, which is excess sweating, and tachypnea, which can result in respiratory alkalosis. If any of these manifestations develop, stop taking therapy immediately so the serum level of aspirin does not continue to rise. To prevent Ray's syndrome in children and adolescents who have viral infections, recommend the use of acetaminophen or Tylenol instead of aspirin or NSAIDs. When NSAID therapy is necessary, recommend non-aspirin NSAIDs for short periods and in low doses to help minimize adverse drug reactions. We also need to monitor for manifestations of embolic events. If a provider prescribes NSAIDs for long-term therapy, we need to make sure the provider also prescribes a low-dose aspirin to prevent embolytic events. Providing instructions about NSAIDs, tell clients to take the medication with food, milk, or 8 ounces of water to minimize gastrointestinal effects. Avoiding alcohol also minimizes adverse gastrointestinal effects. Tell clients to report persistent gastric irritation and manifestations of bleeding, such as easy bruising, petechiae, coffee ground emesis, and excessive bleeding from minor injuries. Also tell clients to report any unusual or prolonged bleeding, as well as changes in urine output, weight gain, or manifestations of fluid retention, such as edema or bloating. Educate caregivers not to administer aspirin or NSAIDs to children or adolescents under the age of 18 who have viral infections. Instruct them to administer acetaminophen instead. Due to the risk of development of thrombi when taking a non-aspirin NSAID, tell clients to immediately report to the provider manifestations of myocardial infarction, such as chest pain or heaviness and shortness of breath, as well as manifestations of stroke, such as sudden and severe headache, one-sided numbness, weakness, visual disturbances, or confusion. If a daily low-dose aspirin is prescribed by the provider to minimize the risk of MI and stroke, reinforce to the client the importance of taking it. Instruct clients to report tinnitus immediately, as this is the first manifestation of salicylism, as well as unwarranted sweating, headache, and dizziness. They should stop taking aspirin if these manifestations develop. Salicylism can happen accidentally to clients who self-medicate with aspirin and to clients who take the medication regularly for a chronic condition such as rheumatoid arthritis. It is important for clients to know what manifestations indicate toxicity is beginning to develop before more serious adverse drug reactions occur. The earliest manifestations of salicylism are decreased hearing and tinnitus, which is ringing or humming in the ears. Headache and dizziness are additional manifestations of toxicity that can accompany the tinnitus. If clients quit taking aspirin at the first manifestations of tinnitus, The blood level will gradually drop as it is excreted by the kidneys. If the clients continue to take aspirin, they will begin to experience nausea and vomiting, diarrhea, and diaphoresis. With continued ingestion, fever, confusion, seizures, and respiratory and/or renal failure can develop from salicylism. Be sure clients know the manifestations of salicylism and measures to take if they begin experiencing them. There are many contraindications to using aspirin. First, it is a pregnancy risk teratogenic medication, so women who are pregnant should not take it. Clients who have peptic ulcer disease or a bleeding disorder such as hemophilia or vitamin K deficiency, and children or adolescents with chickenpox or influenza should avoid taking aspirin. This slide is a good summary of the most commonly tested on things about NSAIDs. NSAIDs inhibit COX-1 and COX-2 enzymes. They can cause nephrotoxicity or kidney damage. The common side effect of NSAIDs is GI upset, so we want to take food to reduce those symptoms. We do not give NSAIDs to patients with asthma, and patients need to report symptoms of a GI bleed immediately if they're taking NSAIDs. Another type of NSAID that treats pain is COX-2 inhibitors. In addition to treating mild and moderate pain, COX-2 inhibitors also suppress inflammation, reduce fever, and treat the pain of dysmenorrhea. The prototype medication for COX-2 inhibitors is celecoxib. Celecoxib is a second-generation NSAID that was developed with the hope that the adverse drug reactions related to COX-1 would be eliminated. The gastric adverse reactions of COX-2 specific inhibitor NSAIDs are less. The renal impairment and adverse drug reactions are similar, and vasoconstriction combined with platelet aggregation actually increases the risk of cardiovascular events. COX-2 inhibitors do still effectively suppress pain and inflammation. There is continuing research on the safety of celecoxib. Increased risks of GI complications can relate to the length of time clients take the medication or the client's age, as well as concurrent ingestion of alcohol or smoking. Increased risk of thromboembolic events can relate to the length of time clients take celecoxib, as well as a previous history of heart disease. In the meantime, clients taking COX-2 inhibitors should be aware of the early manifestations of GI bleeding, such as coffee ground emesis or black tarry-looking stools, myocardial infarction, such as heaviness in the chest and or shortness of breath, and stroke, such as one-sided numbness or weakness and confusion. These manifestations indicate the need for immediate medical care. COX-2 inhibitors is contraindicated in clients who are pregnant. It's teratogenic. Celecoxib is also contraindicated for clients who have severe hepatic or kidney impairment, children under 18, clients with GI bleeding, anemia, pain from coronary artery bypass grafting, and an allergy to sulfa and or sulfonamides. Celecoxib interacts with furosemide or Lasix, decreasing its diuretic effects. Celecoxib increases the anticoagulant effects of warfarin. Glucocorticoids and alcohol taken with celecoxib increases the risk of bleeding. And the antihypertensive effects of ACE inhibitors decrease when you give them concurrently with celecoxib, and there is an increase in the risk of lithium carbonate toxicity. The last group of non-opioid medications to help relieve pain is the dual mechanism analgesic agents. These treat moderate to moderately severe pain. The prototype for dual mechanism analgesic agents is tramadol. There are other types of medications that treat pain by acting on the central nervous system, but we will be focusing on tramadol. Tramadol exerts its pharmacologic actions by binding to selected opioid receptors and blocking reuptake of norepinephrine and serotonin in the central nervous system. Adverse drug reactions of tramadol are rare, but when they do occur, they include sedation and dizziness, as well as headache, nausea, and constipation. Respiratory depression is rare, making this medication valuable in the treatment of moderate pain. Seizures can occur in clients taking tramadol, so those with a history of seizures should avoid taking this medication. Also, some clients can experience urinary retention. Next, the non-opioid analgesic acetaminophen treats mild to moderate pain and reduces fever. The prototype for this class is acetaminophen. Acetaminophen is its own prototype medication. Acetaminophen provides many of the same benefits as COX-1 and COX-2 inhibitors, but without serious adverse drug reactions when taken in therapeutic doses. You can administer acetaminophen orally or rectally. Adults and children over 12 should not take more than 4 grams of acetaminophen a day. Caution clients that acetaminophen is available in many combination products such as cold preparations, so they need to read labels carefully to avoid overdose. Acetaminophen is particularly toxic to the liver when clients ingest more than 4 grams per day. Many combination cold preparations contain acetaminophen for the aches and pains of colds and flu. Unless clients know how to read the label, they may not realize that acetaminophen is one of the ingredients. If a client takes 2 extra strength acetaminophen tablets, which equals 1,000 milligrams, 4 times a day, they will receive their maximum dose. If they concurrently take a combination cold medication that also contains acetaminophen, they will be ingesting a potentially toxic amount of acetaminophen in a day's time. Ingestion of toxic doses can cause toxic hepatitis with liver damage and scarring that occur over time and can develop into liver failure. Acetamin is a COX inhibitor, but its effects are limited to the central nervous system. It still effectively relieves pain and reduces fever, but due to a lack of peripheral inhibition, it has no anti-inflammatory or anticoagulant effects. Again, it has no anti-inflammatory and no anticoagulant effects. It also doesn't adversely affect the gastric mucosa or platelets, significantly decreasing the risk of gastric ulcers and cardiovascular events. Adverse drug reactions of acetaminophen are limited to liver damage when you give the medication in toxic doses over a long period of time, and hypertension with daily use, particularly in women. There are only a few contraindications and precautions that relate to the use of acetaminophen. Clients who have alcohol use disorder should not take acetaminophen due to the potential for this medication to cause an adverse drug reaction in the liver. Use this medication with caution in clients with anemia, immune suppression, and hepatic or renal disease. Alcohol increases the risk of liver injury when it interacts with high doses of acetaminophen. The use of acetaminophen concurrently with Coumadin or warfarin increases the risk of bleeding. When administering acetaminophen, monitor for early manifestations of overdose or poisoning, including abdominal discomfort, nausea, vomiting, diaphoresis, and diarrhea. Liver damage can occur within 48 to 72 hours when acetaminophen is taken in toxic doses. To reverse the overdose and reduce liver injury, acetylcysteine is administered. The medication can be given either orally or intravenously. Also, clients who take acetaminophen on a regular basis, especially women, should have their blood pressure monitored. So acetylcysteine is the antidote for acetaminophen. Acetylcysteine is the antidote for an overdose of acetaminophen or Tylenol. Again, a summary slide that shows the most commonly tested on facts about acetaminophen, which is an analgesic, is that acetaminophen can cause hepatotoxicity, which is liver damage. Acetaminophen is not an anti-inflammatory like other NSAIDs. Acetylcysteine is the antidote. Alcohol use should be decreased or discontinued with use because of the hepatotoxic effects. And we should limit our daily intake to 4,000 milligrams or less. The slide says 3,000, but ATI says 4,000. For a review of aspirin, the trade name could be Bayer or Ecotrin. It's an analgesic, so acetylsalicylic acid equals aspirin, otherwise abbreviated as ASA. Aspirin stops or prevents pain and inflammation from occurring by inhibiting prostaglandin synthesis and blocking the COX enzyme. Aspirin decreases platelet aggregation, so we can use low-dose aspirin for clot prophylaxis. This can decrease the risk of a myocardial infarction and strokes in those with coronary artery disease. No side effects of aspirin, which is an analgesic, include abdominal pain and cramping. Coffee ground emesis, which is dark red, is emesis or throw up is old blood, and bright red means there's an active bleed. Hematuria, blood in the urine, is a side effect that could happen from aspirin because of the increased risk of bleeding, as well as hemoptysis, which is coughing up blood from the lungs. And then, of course, black tarry stools can indicate a side effect of aspirin. Other must-know side effects of aspirin is GI upset, which can cause nausea, diarrhea, and vomiting. Angina after exercise due to vasospasms from aspirin, or mental status changes, which could indicate toxicity or salicylism. Contraindications again: do not give aspirin to patients with bleeding tendencies or bleeding disorders. Do not give aspirin to patients with an active bleed like a GI bleed or a bleeding ulcer. Do not give aspirin to patients who are currently taking anticoagulants like warfarin or heparin. And do not give aspirin to patients with a vitamin K deficiency, because vitamin K helps the body to clot. So if they have a deficiency, they're going to be more likely to clot, and we don't want to add aspirin to that. Education specific to aspirin includes stop taking it 1 week prior to any major surgery. Do not give aspirin to children who had a recent or current viral infection, because they could develop Ray's syndrome, which is encephalitis and hepatotoxicity. Clients should be taught to report signs of a GI bleed, which are those symptoms of black tarry stools, coffee ground emesis, vomit that looks like coffee grounds, and then unresolved abdominal cramping. Most commonly tested on aspects of aspirin include stop taking it 1 week before major surgery, report signs and symptoms of bleeding immediately, do not administer aspirin to patients who have bleeding issues or vitamin K deficiency, and do not administer aspirin to children who have recently had a viral infection because of the risk for Ray's syndrome. This is a great comparison slide showing that NSAIDs like ibuprofen treat pain, treat inflammation, and can bring down fever, but they are not antiplatelet. They are safe for children, except for, they are safe for children. Major complication could be nephrotoxicity. They hurt the kidneys. Aspirin works for pain as an analgesic. It's an anti-inflammatory. It can bring down fever, and it's an antiplatelet, but we don't want to give to children because of the risk of Ray's syndrome, and the major complication for aspirin is bleeding. Then acetamin Tylenol, it is an analgesic. It is not an anti-inflammatory. It is an antipyretic, so it'll bring down fever. It is not an antiplatelet, but it is safe for children. The major complication for acetaminophen is hepatic toxicity, which means it hurts the liver, and high doses, over 4 grams per day. So I think acetaminophen, Tylenol, think A+, because you can give it pretty safely with a lot less side effects than the other NSAIDs and medications. Now we're going to talk about another class of analgesics called opioids. Opioids, also called opioid agonists, serve as an analgesic for moderate to severe pain. The medications are also used to induce sedation and lessen anxiety in preoperative clients. Morphine is the prototype medication for this class, and it is one of your drug cards. Other medications in this category include fentanyl, meperidine, hydromorphone, and methadone. Methadone is a synthetic opioid that's chemically similar to morphine, but is used primarily as a substitute for opioids in substance abuse disorder programs. Methadone blocks the euphoric effects of opioids and reduces cravings in people addicted to a medication in this group. Other common opioids include codeine, oxycodone, hydrocodone, etc. It's a good practice to obtain clients' baseline vital signs before administration of opioid analgesics, and they should be continually monitored throughout therapy. Opioids can be given orally, intramuscularly, intravenously, subcutaneously, rectally, or epidurally. If you're giving a sustained release form of opioids, we want to make sure we do not crush or chew them. IV opioids should be diluted per provider recommendations and given slowly over several minutes. Patients receiving opioids should have naloxone, which is an antidote readily available. When giving opioids to cancer patients for terminal cancer pain, the medication should be given on a fixed around-the-clock dosing schedule rather than as needed. Opioids mimic the actions of naturally occurring opioids, endorphins, and enkephalins. They do this by binding with the mu receptors at the opioid receptor sites. Stimulation of these receptors causes analgesia, sedation, euphoria, and respiratory depression. Therapeutic uses for opioids include to decrease anxiety and anxiety attack, especially those attacks that include dyspnea and shortness of breath. Opioids can be used for intraoperative and postoperative sedation. Opioids can be used for end-of-life comfort care. They decrease the respiratory distress and they provide pain relief. Opioids mainly are used, though, for pain relief for acute pain or chronic pain, especially that associated with cancer. And then opioids can also be used for chronic diarrhea and intestinal cramping. So opioids slow GI function. We talk about drug tolerance with opioids. That means the body gets used to them and the original dose won't provide the same therapeutic effect. So a higher dose of medication is needed to achieve the same effect. So if you took one pill and you become tolerant to it, you're going to need 2 for it to make the same kind of effect therapeutically. When instructing clients on how to take opioid analgesics and minimize adverse drug reactions, emphasize that they should only take the medication when they need it and on a short-term basis. Patients should know not to take an opioid agonist prior to driving or activities requiring mental alertness. And when feeling lightheaded, patients on opioids need to make sure they know how to sit or lie down immediately. To prevent and/or treat constipation because of the slowing of the GI tract, clients should be told to increase their fluid and fiber intake as well as increasing their activity and exercise. Opioid analgesics can be taken with food or milk if nausea and vomiting occur after taking an oral form of the medication. Occasionally, opioids can cause urinary retention, so we need to watch out for that. We ask that patients tell us to report any difficulty or inability to urinate. And finally, we encourage clients on opioids to cough regularly to clear secretions from the throat and chest to prevent pneumonia because of that decreased respiratory. Many of the adverse drug reactions of opioids, such as respiratory depression and sedation, occur secondary to stimulation of the mu opioid receptors. Effects that often accompany sedation are dizziness, lightheadedness, and drowsiness. Another common side effect of opioids is constipation because they decrease intestinal motility. Because of that reason, opioid-related medications such as loperamide treats diarrhea. Opioids' dilating effects on peripheral vasculature can cause orthostatic hypotension. They can also cause urinary retention by decreasing the client's perception that the bladder is full. Cough suppression is an adverse drug reaction of opioids unless you give them to suppress coughing as part of a treatment regime for an upper respiratory infection. Those are usually called Tessalon pearls. Due to the euphoria that occurs secondary to stimulation of the mu receptors, opioids have a high potential for misuse. And then again, tolerance and cross-tolerance with other opioids develops with chronic use, requiring larger doses to achieve the usual effect. Think low and slow when remembering all the signs and symptoms of opioids. They slow the central nervous system, so they cause sedation, they can cause sleep or insomnia, they slow your muscular system, so they can cause weakness, and they slow and can cause hypotension or dizziness. The use of opioid analgesics is contraindicated in women who are pregnant because morphine is a pregnancy risk medication if clients use it on a long-term basis in high doses or near term, as it can result in respiratory depression of the newborn or lead to neonatal opioid withdrawal syndrome. Opioids are also contraindicated for clients who have renal failure, increased intracranial pressure, biliary colic, or biliary surgery, as well as clients in preterm labor. Use opioids with caution in all clients because it's a Schedule II controlled substance. Due to the adverse drug reactions, we have to administer it carefully to older adults and infants, as well as clients with reduced respiratory reserve, head injury, inflammatory bowel disease, prostate enlargement, hypotension, and hepatic or renal disease. Opioid agonists interact with CNS depressants such as barbiturates, phenobarbital, benzodiazepines, and alcohol by increasing their central nervous system depressant effects. When you give this medication with anticholinergic agents such as antihistamines and tricyclic antidepressants, their anticholinergic effects increase, causing constipation and urinary retention. The concurrent use of opioids with antihypertensives increases their hypotensive effects, and St. John's wort may increase sedation. Finally, meperidine can interact with MAOIs, which are antidepressants that clients take together, and it can cause hyperpyrexia syndrome, which manifests as excitation, seizures, and hyperpyrexia, which is a highly elevated temperature. Again, one of the must-know side effects for opioids is slow GI function, which could cause constipation. Recent studies have shown that clients in acute care settings are more often under-medicated for pain than they are over-medicated. The reason for under-medication often relates to the concern about the potential for dependence. However, on a short-term basis, there is little to no risk of dependence developing. For clients hospitalized for a long period of time and taking opioids during this time, some level of physical dependency may develop. Gradual withdrawal of the medication over a period of several days when the pain resolves allows the body to adjust to the decreasing dose and minimize physical manifestations of withdrawal. Opioid withdrawal manifestations include abdominal cramps, diarrhea, agitation, anxiety, hypertension, tachycardia, tremors, muscle pain, pupil dilation, runny nose, and insomnia. Opioid use disorder, however, requires a client to have a strong desire for the medication in the absence of pain. This should not be a consideration when treating pain in a client who is post-operative or recovering from trauma. The amount of pain a client is experiencing is based on what the client says it is, and so you should treat it accordingly. The antidote for opioid overuse is naloxone, otherwise known as Narcan. You should give Narcan when patients taking opioids have a respiratory rate less than 12 or if the client is unarousable. Repeated doses may be necessary and patients may be combative after administering naloxone. Naloxone can wear off in 1 to 2 hours, so we may need to repeat those doses. Opioids last longer than the effects of naloxone, so remember that. Naloxone can be given via several routes, such as intranasal spray. It can be given intramuscularly, subcutaneously, or intravenously. When caring for clients taking opioid analgesics, closely monitor their vital signs and oxygen saturation and make sure to auscultate the lungs for congestion. Since one of the most serious adverse drug reactions of opioid is respiratory depression, observe for a decrease in rate from the baseline. For rates below 12 minutes, withhold the medication and stimulate breathing. If necessary, administer naloxone to reverse respiratory depression and restore respiratory rate. Monitor clients when ambulating in case they experience orthostatic hypotension from the opioids. Due to a risk of constipation, monitor bowel function and provide fiber supplements and stool softeners as needed. For vomiting, give opioids with food and administer an antiemetic as needed. We need to make sure clients are receiving adequate hydration either orally or intravenously when getting opioids. We also need to monitor intake and output and watch for manifestations of urinary retention, such as bladder distension. It's a good idea to encourage clients to urinate every 4 hours since their perception of the need to urinate diminishes when taking opioid agonists. Prepare to insert a urinary catheter to drain the bladder if the client is unable to urinate and bladder distension is evident. Also teach patients that opioids can be addictive and they should only take them as prescribed. The summary is most commonly tested facts about opioids is that respiratory depression is the most serious adverse reaction. Naloxone should always be available when opioids are being used. It should be administered for respiratory rate less than 12 breaths per minute or if the patient is unarousable. Common side effects of opioids include slow central nervous system, low vital signs, and slow GI function, which can lead to constipation. Also, due to increased drowsiness, assistance should be provided with ambulation for patient safety and to prevent injuries when taking opioids. Fentanyl is a very strong opioid that can be used via a transdermal patch. We use transdermal fentanyl patches for chronic persistent pain like cancer pain because they can provide relief of pain for up to 72 hours. Things to remember with a transdermal fentanyl patch: you have to rotate the application site, never put it on the same site twice. Discard appropriately, fold the adhesive side together, place in a designated bin or trash, and keep fentanyl patches away from children. We always place the patch in a clean, dry, hair-free area, and the patient is allowed to swim or shower with the patch in place. We also never cut the patch in half. Things to avoid is to not apply a new patch while an old patch is still applied. Again, we should not cut or alter the patch. We should make sure the patch is not exposed to prolonged heat, so fever, hot tub use, heating pads, or saunas are not recommended. Adjuvant medications for pain are used with a primary pain medication, usually an opioid agonist, to increase pain relief while reducing the dosage of the opioid agonist. Reduced dosage of opioids results in reduced adverse reactions like that respiratory depression, sedation, or constipation. Targeting pain stimulus using different types of medication often provides improved pain reduction. Although adjuvants can relieve pain, they were developed to treat other conditions. So remember, adjuvants help to relieve pain in conjunction with an opioid, but they were developed to treat other conditions first. Categories of adjuvant medications include tricyclic antidepressants, anticonvulsants, the tricyclic antidepressant like amitriptyline. There could be anticonvulsives like carbamazepine or gabapentin. CNS stimulants like methylphenidate can also help when given with an oral opioid. Antihistamines like hydroxyzine can help. Glucocorticoids like dexamethasone can also increase the effects of opioid pain medicines. NSAIDs like ibuprofen can help. And then tricyclic antidepressants like imipramine, amitriptyline, anticonvulsants like phenytoin, CNS stimulants like dextroamphetamine, glucocorticoids like prednisone, biphosphates like pamidronate, and NSAIDs like ketorolac, which is Toradol. These medications should be used in combination with opioids, but they cannot be used as a substitute for opioids. Migraine headache pain can be caused by the inflammation and vasodilation of cerebral blood vessels. Medications for migraine headaches can be used to stop a migraine, which is called an abortive medication, or they can prevent one from occurring, which is considered prophylactic. First-line treatment for migraine headaches includes nonspecific analgesics like aspirin-like medications and migraine-specific medications like serotonin receptor agonists, also known as triptans. Ergot alkaloid medications are second-line treatment for migraines, and prophylactic medications include beta blockers, anticonvulsants, tricyclic antidepressants, and estrogens. Local anesthetics block motor and sensory neurons to a specific area. They can be given topically, injected directly into an area, or given regionally, epidurally, or into the subarachnoid space. This is another good summary to finish up of the complications of different types of analgesics. So NSAIDs like ibuprofen can be nephrotoxic, which means they hurt the kidneys. So NSAIDs, think nephrotoxic. Aspirin, the complication mainly is bleeding. So aspirin ASP, think a slippery platelet or bleeding is the common complication for that. Acetaminophen can cause hepatotoxicity in high doses, which means liver problems. And opioids can cause respiratory depression,